views, information, or opinions expressed during AAOA broadcast series are solely those of the individuals involved and do not necessarily represent those of the American Academy of Otolaryngologic Allergy, its employees, or members. The AAOA is not responsible and does not verify for accuracy any of the information contained in and assumes no liability for any activities in connection with these broadcasts. The primary purpose of this broadcast series is to educate and inform and does not constitute medical or other professional advice or services. Advertising which is incorporated into, placed in associate with, or targeted toward the content of this product without express approval and acknowledgement of the AAOA is forbidden. These broadcasts are available for private, non-commercial use only and may not be edited or modified from their original form or reproduced for distribution.
Good evening. My name is Keith Sale. I'm a practicing otolaryngologist at the University of Kansas Medical Center and Health System in Kansas City. Tonight, we're going to talk about all things telehealth. It's all the new rage during the pandemic, and it's a fantastic way, in my mind, to connect with patients during a difficult time when patients maybe either don't want to come in to see us or can't come in to see us. We have a wonderful panel of experts tonight who are going to talk to us about their experience with telehealth. So I'm going to let you guys start. Marina, if you want to lead us off and kind of walk us through your information and your background.
Sure, thank you. My name is Marina Boruk. I practice in Brooklyn, New York, in the heart of it all right now. I'm an academic faculty practice with SUNY Downstate, and my main subspecialty is rhinology.
All right, Alpen, how about yourself?
Sure, thanks, Keith. So my name is Dr. Alpen Patel. I'm your AAOA president, and I'm excited to be part of this panel. I have no conflicts of interest to disclose, and I'm in a single specialty private practice setting in the Baltimore area.
Excellent. And I forgot to mention, nobody's paying me to be here either, unfortunately, so I have no conflicts of interest. Marina, do you have any conflicts?
I will follow my only potential conflict of interest is one time served as a participant on an advisory board for Optinose, but it's not related in any way to telehealth.
Okay, perfect. And James?
So yes, my name's Jim Connolly. I am in general ENT as well as practice allergy and sleep medicine in the greater New Orleans area, and I have no conflicts of interest.
All right, outstanding, guys. Well, let's start with just kind of maybe explaining. I'm just going to open this up to anybody who wants to speak. Just walk us through a little bit about how COVID has impacted your face-to-face practices.
I have not, since due to my practice of rhinology and the need to scope majority of patients and currently what has been going on over the last 5 weeks in New York, I have not been seeing patients face-to-face. There have not come up any emergencies. However, my practice has been open to somebody who needed for a nosebleed or something else urgent or emergent in the office. Majority of patients have been super understanding, and they have either postponed their visits or just requested refills, or we just went over, reassured, and just followed up on symptoms, or went over anything acute by history via telehealth visit. The video portion of the visits have been super helpful, kind of like face-to-face a little bit. You're still able to judge what's going on with the patient. And also I think it's super helpful to be screening patients, and that's where kind of, it's been helpful, but that's about it. And we're planning to reopen at least very slowly, a trickle, in the next coming few weeks.
Sure.
We closed down probably mid-March as the pandemic began in the state of Maryland, and started doing more and more telemedicine. We added a module to our EMR system and integrated it in using Zoom technology, and starting seeing new patients as well as our established patients using telemedicine. We kept the office open for emergencies and urgencies, whether it was the epistaxis patients or abscesses that needed to be drained, or even new cancers, that sort of thing. But it's been helpful, I think, for our patients in the sense that obviously there's a convenience factor. One of my offices requires paying for parking if you're there for more than an hour, so they save that cost. Obviously the time savings, and but in the absence of the exam, we've been able to manage our patients. But some patients do need to come in, and so we've been waiting for that to happen, which will be happening in our office in the next week or so.
So I would say our experience in the greater New Orleans area is very similar to Alpine's in the fact that it was about mid-March that we had everything kind of change on us dramatically. We were very lucky to be able to also integrate the telemedicine very quickly into it. And so we were able to convert most of those patients to a telemedicine visit or phone call visit at that time, as the patients were scrambling for technology to be able to do the telemedicine themselves or the knowledge base to be able to do that. I would say probably we're at 80 to 20% now.
80%?
80% telemedicine.
Okay.
No, we use DoxyMe.
Doximity? Okay, perfect. And Marina, what platform are you guys on?
So we just kind of asked patients what it is, and we gave them a few options, what it is that they preferred or they had available. It is not part of our EMR currently, but we offered Zoom, we offered Skype, and we offered WhatsApp. And I noted that for the most part, only those who are probably over the age of 70 who truly preferred a telephone call and were not, able with ease to hook up to an app on the phone. That worked pretty nicely. There are pluses and minuses, certainly. I found Zoom was the easiest, but that required an email from a patient to send them the invite. On the bright side, once we get an email, they're also able to sign up for a patient portal. So I use that as an opportunity to also, create patient portals with them, for them, an account. So because as we talk, there is nothing that for them that we have to print out that they would otherwise take home as their clinical summary at the end of the visit. So I always would go over to, and encourage them to sign up to review what we talked about. And, also if they need to reach back or contact us. And for example, as part of this whole pandemic and the closures, we reduced and closed our office 1 day a week completely for the staff, for the patients, for the physicians. So we're operating at only 4 out of 5 days a week.
Yeah, so for us in Kansas City, I think it hit us right around mid-March as well. I know because I had to cancel my spring break trip to the Caribbean on the 15th. To me, that's like Pearl Harbor Day. It was just a day that's going to go down as a very sad day for our household. However, we, as a practice, ground everything to a halt. It really was a complete standstill, mostly because we were being very aggressive and trying to limit our exposure, much like the rest of y'all. Really open just for emergencies, and then tried to convert to telehealth as quickly as possible. Our health system basically transitioned from a 2-year process to a 2-week process and got Zoom set up with Epic. And so we took off pretty quickly as an organization and really only use Zoom. I would say probably 90% of the time. 10% of the time when it doesn't work, we have audio issues, we flip over to Doximity. Mainly we use those two because they're the two HIPAA compliant ones that we have access to. For us, Skype and FaceTime and some other things, just we tried to shy away from those unless it was absolutely critical. The good news is the government right now is covering all of them and has relaxed those HIPAA restrictions, so there's really not any downside using anything else. But we were trying to prepare kind of for the long haul, thinking this might be around for a while to come. So as you guys have integrated telehealth into your practices, do you feel like, you mentioned you're 80-20, James, and so are the rest of y'all feel like that you've shifted and are you recapturing some of that same level of volume you were seeing in your clinics pre-COVID?
I would have to say that no. Majority of the patients, at least in my practice of rhinology, and I'm in a single specialty, but multiple subspecialties of ENT, but part of the rhinology specialty, majority of my patients that kind of need, especially follow-ups, post-operative follow-ups, I really need to see how they're doing, with the telescope. So if they're doing well, they'll usually opt to postpone the visit. If they need something else or they have questions, then we did a televisit, but a lot of them have postponed visits. The new patients, it was interesting because some of them would have complaints, and based on their symptoms, I had the opportunity to counsel them that they were having symptoms probably of the COVID-19. So with hyposmia, anosmia, so kind of it was helpful, and they were very appreciative, just getting that information and insight into, what to expect and what to do, reassurance, as we scheduled them for follow-up.
Well, our volume is definitely not as much as it was prior to COVID-19 and the pandemic. We just now, right before we're about to open our offices in the next week or two, are starting to get back at that same volume using the telemedicine platform. And like you, Keith, we use the Zoom, as I mentioned, but we also use the Doximity video system as well, since it is HIPAA compliant. But it's been challenging. We've tried to keep our staff. We haven't furloughed anyone, and we're looking forward to the next few weeks as far as reopening. We do think that telemedicine is going to be around for a while, whether it's a pandemic and a second peak or surge that occurs, or the fact that it's just another avenue to evaluate and manage patients who might not be able to come to your office or might not be interested in coming to your office. So I think it'll play a role for us in the near future and maybe even the distant future as well, especially if the payers continue to recognize it and reimburse for it. But yeah, the volume was definitely not the same once we transitioned to telemedicine in mid to late March.
Sure. So James, as you mentioned your 80/20, that's a pretty significant shift, obviously, from pre-COVID. Tell me about how you guys are keeping up with the billing piece of that too.
Yeah, so for us, at least for myself in my practice, I went 80/20 on the telemedicine. Now, I'll say a week ago, we got cleared by the state to start opening up our clinic and start seeing more patients in the clinic. And so it may not be 80/20 this week, but it's slowly coming back. It's definitely 75% of the patients at this point, where it was 25% the first week into it. My practice is made up of not only allergy, but sleep medicine. And so it put me in a specific position that my partners were not in, of dealing with more chronic issues than always acute issues. And so those patients lend themselves to telemedicine much better. And so they were just happy not to have to come into the office, and they're going to probably be very persistent about keeping this. So hopefully the insurers will allow us to feasibly do that. From the billing side of it, we held all of our claims for approximately 3 to 4 weeks until we could see how things were going to pan out. And after the insurers have given us more information, we've processed some of those, and we're hoping that was correctly done, or we'll have to reprocess it. And I do know that there's some that have already changed their reimbursements that originally were going to be much lower, and now they've back and said that they're going to be higher. So we'll have to see if we have to reprocess those as well.
Sure. How about the rest of y'all? Billing compliance alerts seem like change. It was almost every day for the first couple of weeks of this whole craziness. And now they've kind of slowed down a little bit, but even yesterday, I think, or last week, they came out with another alert saying that you can bill the same for a telephone visit as you can for a in-person visit, which is an even bigger shift from when we started all this. Have you guys had problems at all trying to get through the billing compliance piece of this in your other practices, Marina or Alpen?
We just initially at the very get-go tried to do a lot of research and figure out, the how to bill as far as the place of service, with CMS and different insurances, and every insurance has a different sub plan, whether it's a Medicare Advantage or a Medicaid HMO or just a private insurer. And each of those plans was requiring a different, kind of way to bill it. I'm not necessarily in the loop with all the billing details, but those were points of discussions in the beginning. The modifiers, what is it that you want to append? How are they going to tell that this was a televisit and not an in-person face-to-face visit? How are they going to tell the place of service? Some of the insurances required that we bill a consult fee for the consult code for this. Medicare has its own set of rules. So it was very tricky, but we'll see. I have no idea how that's going to shake out.
Okay. How about you, Alpen?
Yeah, I found the experience very challenging and frustrating because of the lack of uniformity. I almost wonder if it was intentional by the payers, so that you have to figure out what the POS is or point of service is for one, and the modifier. I remember early on, Medicare patients were having a point of service of 2, and then several weeks back, that changed to 11. So even within the same payer, that changed. So you had to keep up with that. And maybe the way to do it was what James did, which is to hold on to all of these fee sheets and charges, and then wait it out and see what the final word was as far as the correct modifier and the correct POS or point of service before submitting for reimbursement. But it's been tough keeping up with it as things have been changing left and right over the last 4 to 6 weeks. But hopefully we have some cash flow from it to float the practice, and hopefully it gets better and maybe more uniform from payer to payer.
Yeah, I think it's been a challenge for a lot of folks. I think we did a lot like your practice did, James. As an organization, we held our billings for quite a while just because things just kept changing so frequently, and it just didn't make sense to bill. And now for us as a health system, they've also allowed us to bill, hospital as a site of service. So you can collect both your facility fee and as the originating site for your telehealth visit, in addition to your professional charges. So it's just like seeing the patient in a provider-based clinic now, which again, 4 or 5 weeks ago wasn't even an option. Not to mention telephone visits and how they're paying for those now. So yeah, it's been a little bit crazy as they've changed those compliance alerts. I feel like our office is coming out with a new compliance alert every other week. So let me ask you about challenges and barriers. One of the consistent things I hear a lot of is, oh, this isn't good for the old folks. The older people really can't do telehealth. Tell me, what are some of the barriers and challenges that you guys have seen with some of your patients and your populations, and shed some light on I think of it as a myth, but if you believe in the myth or not, that older folks, the older generation might struggle with telehealth.
I guess one of the challenges that I found is to make the flow, the workflow for the office staff, because this is all new for the office staff, for the front desk, for the medical assistants, for me. Everything is new. So really working out the kinks, how to say, what to say, since we are billing these visits, these televisits, the staff had to be also cognizant to check, to run eligibility and to make sure that they have the correct insurance and they have all of that, because without actually having the cards, the IDs, especially for new patients, and verifying information for the established patients is just as important for the follow-ups.
I agree with Marina. I think there's obviously a learning curve for the staff and for the providers and the patients, but I think it's sort of like riding your bike. The more and more you practice, you remember the workflows, whether it's downloading an app or having the software or unmuting yourself or having the video camera on. I think the challenges that we face still to this point, despite learning the workflows and improving those for all stakeholders, is the fact that sometimes you have a weak signal either on your end or on the patient end. Sometimes they don't have a video compatible device, whether it's a smartphone, a tablet, a laptop, or a desktop. So that becomes challenging if you're trying to achieve that synchronous audio video telemedicine component. And then, of course, there are some folks that even if you try to troubleshoot them, they're just technically challenged. And so oftentimes we'll revert to audio only at that point. And as you mentioned, Keith, last week, CMS improved or increased the payments for the audio only portion using the telephone codes to match up the in-office E&Ms. So I think that'll be helpful as well for some of these folks who just can't figure out how to use the video portion of it.
I would agree with all of those statements. I think the people that telemedicine in my practice lends itself to are also the people that maybe technology are not the savviest at it. And so it's like the perfect thing for them once you can get them capable of doing it. And so we continue to have issues with that from time to time, but once we're able to get them to do it once correctly, then it's very easy for every follow-up. And I have had some people that needed 1 or 2 follow-ups since initially seeing them by telemedicine. And so we do have some follow-up with those patients with that same technology going through it. And I have to say, there hasn't been a whole lot of negative feedback on the second or third telemedicine visit. The first visit, that's a different story. Sometimes the frustration of making sure that your video and your Wi-Fi is strong enough to be able to keep a synchronous video has been challenging. From our perspective of the clinic, maybe just everybody's on the Wi-Fi and now we're getting knocked off, or the patient who may be living in the countryside that doesn't really have great reception.
Yeah, I agree with all those points. I think, in the clinic, the workflow is something that's really important to figure out up front, and doing some of that pre-visit work and prep with Zoom or Doximity or whatever ahead of time can sometimes help those patients navigate that first experience. Because I agree, we've had some challenges with that first experience, but once they've had a telehealth visit, almost universally they love it. I love to dispel the myth of age as a barrier, because our oldest patient so far was 100 years old. Now, she did have a much younger husband helping her out at 99, but the two of them were really able to navigate Zoom. So I don't think age is really a barrier. And I've gone down personally and seen patients as young as 14 months. And so I think you can really span the entire spectrum with telehealth. So I think there's some workflow challenges like y'all mentioned, occasionally some technology challenges, but not a lot of true barriers beyond those to really opening up telehealth to a lot of folks. So with that in mind, then, is telehealth a good fit for otolaryngologists, not only during the pandemic, but post-pandemic?
So I think even at the tail end of pandemic, until this is all truly over, I believe we will continue to use telemedicine to at least kind of touch base with the patient before they come in to see, the front desk screens them, but we can also take the history and see how they're doing. If there's any question, that the screen didn't pan out with the front desk and they need to be seen, they need to, they need our care, they need our help as an otolaryngologist or allergist. However, long term, I think there has been a lot of adjustments in the whole policy for telemedicine during the pandemic. I think that's the 1135, the amendment that they did to the telemedicine rule. I live in Brooklyn, which is not a rural area by any means. So I do not know if they will keep this rule, indefinitely or long term. For the patients to be able to use telemedicine when their doctor is 2 blocks away. I know that previously telemedicine was only allowed from a physician's office to another medical facility or physician's office, and now we're able to communicate with patients and be in touch with them when the patient is in their home, when the patient maybe potentially is in the hospital, when the patient is, at work in their office. I've had some of those. They schedule an appointment and then they take a break. So it's just interesting to see how this is going to pan out long term.
So I feel like the cat is out of the bag, and I think telemedicine is going to be here for a while for our specialty and probably for the house of medicine. I know you lose the patient touch with telemedicine, and it's hard to do procedures remotely, at least for now. But I think it can be used to evaluate new patients, follow established patients. I think the patients are happy once they figure out how to use it. The same is true for the providers and the staff. I think what's really going to drive this is once this pandemic crisis ends, hopefully this year, is are we going to be reimbursed for these audio, video, synchronous visits? If we're not, it may still play a role, but we may ask patients to come in because at the end of the day, we still need to meet our expenses. And obviously, this doesn't replace the in-office visit because there's really hardly any examination with telemedicine. So like Marina said, we'll see what happens, but I think the patients and the providers are really going to push these payers to reconsider allowing telemedicine, maybe not at the same rate, maybe at a lower rate, but I think it's going to remain as an evaluation and management tool for our patients.
I would agree with that. I think the cat is out of the bag in that the public in itself, whether physicians were in favor of it or not, are going to require it. They're going to demand it because it's been given to them across the whole house of medicine. And they're going to say, well, why can't we do that again? I felt like I had good medicine and I want that same thing. Now, is it equal medicine? That's a totally different argument, but the patients are going to demand it for sure. And I think as physicians, what we'll do is we'll find out where it suits our patients best and steer them in those areas, which I really think is in the chronic medicine realm of where people are just managing a problem and we're making adjustments. And most of those things are cerebral. They're not necessarily based on every physical finding. And so I think we're going to find that to be very useful. I think the insurance companies, as well as Medicare and the government insurers, are going to figure out a way to see that these chronic issues that really end up costing a lot of money to these companies as well as to the government, and how we can better manage them than letting them get out of control by making it easier for those patients to be steered in the correct direction. And it's going to take a little while for people to put in the numbers and see why it benefits from them, but I think all parties will find some form of use for this.
I think especially for the follow-up patients where even the AAOA guidelines for documentation, coding, and billing, they do not even require, a physical examination unless it's something very focused, that we sometimes have patients follow up. However, I must say that there are some points of this telemedicine takeaway. I have discovered personally codes that apparently are out there that can be billed and potentially maybe even reimbursed for something that I personally do on a daily basis I did before pandemic and still do. And I was doing it for free. As far as reviewing patients' reports, records, following up with them, requesting records and reviewing multiple pages. This is kind of goes along with online E&M services for the patient, as well as, medication refills, etc. Supposedly, apparently there are codes for that.
Yeah, I think, that there's a bright future for telehealth. I think, it's one of those, like Alpen mentioned, the cat's out of the bag. Now that it's out there, people have seen what the power of it and the ease of it. I think it's here to stay. I think, like you mentioned, James, the key is going to be figuring out in otolaryngology, what are the right patients that belong in that type of a visit? Is it post-op? Is it some of our chronic disease management patients? There's probably a cadre of folks that you could run through quickly in a telehealth clinic in a half a day to free up slots on your schedule then for those surgical patients or for those procedural patients that truly need to be seen face-to-face. I think that's potentially the biggest benefit for otolaryngologists. I mean, could you imagine, I'm thinking in my allergy practice, half the patients I see in a follow-up capacity in my allergy practice could be seen via telehealth. And if nothing else changes the way it is now, I think that would open up a lot more slots in my practice for some of the surgical things I also want to see. So I'd just be curious to see how this develops over time. If you guys could pick one takeaway from telehealth, either a pearl, a cheat code that you figured out for telehealth, or just your favorite story, what would it be?
My favorite story is that one of the patients that I connected with, that I treated and recently actually performed surgery, was a UK native, and he ended up going back home. So I did a telemedicine visit with a patient in the United Kingdom. I don't know how kosher that will be if I bill the insurance or my malpractice, but hopefully nothing bad's going to come out of it.
So I've had a good experience with it so far, and I've actually been waiting for this moment for years because I feel like our specialty is so ripe for telemedicine. There's so much that I can do just listening to the patient without laying my hands on it, and on the patient, of course, and using obviously technology like imaging studies and just the history alone, and audiograms, which can also be done remotely now. A lot of patients can be effectively, or at least initially, managed or worked up. And so I really see that this is going to be part of our future in otolaryngology, and I'm excited to see where this takes us. I think my takeaway would be that for providers out there that aren't doing it or have decided to wait it out and sit on the bench, probably should do it and learn how to do it, and maybe even integrate it into your EMR, because this pandemic, as we know, may be coming back later this year or maybe even next year until there is effective treatment for it, or if it mutates into a less lethal strain. Or, as we discussed, if the coding and billing and recognition are still part of all this, we may be using that as a way to evaluate patients, whether they be new ones or follow-ups, chronic patients, or even acute patients that might not be able to come in for whatever reason. So we'll see what happens.
So I think the interesting thing from where we stand today is how I think it's going to go from 5 miles per hour to 100 miles per hour in the technology sector of taking these platforms that exist now and making them a gazillion times better. And it'll be interesting to see how many spawn off or how they condense down into 3 or 4 platforms that dominate. And I think what we'll find is that they're going to figure out a way that you can show your audiogram, you can show your imaging studies, you can show their labs, all to them while you're there. So it's going to be a very interesting time as it changes. But I think for sure it's here. The question is, how much better does it really get? It's going to get a lot better. And I think as far as the physical exam, I think, there are obviously tools that are already out there that are expensive or maybe not user-friendly to the patient that are going to become easier and better. And I think you're going to find that there's going to be a bigger niche for this than we can even imagine.
Yeah, all great comments. I agree universally with all of them. I think, as we said so many times, telehealth is here to stay. If I were to give you one tip, it would be, I would look for a platform that allows you to share your screen. And I don't know how much of you all do. I share my screen a lot. I love to have OneNote or Word up in the background. I can either type things or I can actually draw. I don't know if you guys like to draw pictures in your practice. I draw a lot of pictures. And so I love to be able to share my screen and then use my iPad to draw pictures for the patient while they're watching. So try and find a platform that allows you to do some drawing if you can. Second thing for the practitioners would be, I agree with you 100% up and get into it. You got to figure this out. This is just like getting an EMR. If you're waiting for and you're still on paper, obviously you are way far behind the times, not being an electronic medical record at this point. If you're also not on a telehealth platform, 3 or 4 years from now, you'll be the same thing as being on paper. You will be well behind the curve. So I would encourage you all to become early adopters and get involved and ride the telehealth wave. Get on it now and see where it takes us. The last thing I would do is I would encourage you to talk to your carriers, talk to your managed care teams, talk to your state senators, representatives, anybody who will listen to you about the value of telehealth so that it stays and so that it continues to be a reimbursable way and platform for us to care for our patients. Because I think it's an invaluable resource for our patients and for us. And it's potentially one of the best ways to combat the doctor shortage that is looming or not, that is already here for us. It's a great way to connect to a lot of patients in a short and effective manner. So with that, I think that concludes our panel tonight. I want to thank Marina, Alpen, and James for joining us tonight for a wonderful discussion on telehealth. Hopefully you all learned quite a bit. And if you have any questions, feel free to reach out to any of us anytime.
Thank you.
Thanks, Keith.
Yeah, thank you.
Bye.